are listening to the Alzheimer's Podcast with Mike Good of Togetherness, your number one resource for practical tips and insights, empowering you and your family to live well with Alzheimer's. Hello and welcome to episode 10 of the Alzheimer's Podcast. I'm Mike Good of Togetherness. I'm excited to have you here for another episode where my goal is always to empower you to maintain a positive experience, reduce and eliminate the need for medications, and make your time together with those you care for the best it can be. This episode is a continuation of my series, which is based on my very popular and free Introduction to Alzheimer's Disease course. In this episode, we start to move away from the basics and start paving the way towards empowering you with the ability to live well with Alzheimer's or another dementia in your life. Just to be clear, I'm not saying this is going to be easy, and I'm not saying there won't be tough times, because there will be. My intention is to help you learn and implement strategies to minimize the ups and downs. If you're a family member, then the goal is to help you maintain a peaceful, loving, and safe home. If you're a professional, the goal is to empower you to help families live well with dementia. Be sure to listen to episodes 7 and 9 to ensure you have a basic understanding of Alzheimer's disease and dementia. In those two episodes, I discussed things such as the relationship of Alzheimer's and dementia, what Alzheimer's is and how it affects the brain, causes, risk factors, research, and much more. In this episode, I'm going to discuss the emotional aspects of Alzheimer's, testing and diagnosing Alzheimer's and other dementia, and I'll introduce you to the dementia healthcare team. In episode 1, and when I give my public presentation on how to help others live well with Alzheimer's, I talk about 8 pillars of care. Right at the very top, the very first thing I talk about are the emotional aspects of having a terminal illness such as Alzheimer's disease. Alzheimer's is a family issue, and we must be aware of the emotional impact on everyone. If the person with dementia and each person in the care circle isn't finding ways to cope with their emotions, then living well or positively with the disease will be much harder, if not impossible. As more awareness of dementia grows, more and more people live in fear of developing the disease. Fear is the first emotion that appears and is in play from the very first time something is considered wrong. Often this is unsubstantiated fear and the person may never develop dementia. But when a person is diagnosed, I've heard several people with dementia say that they actually feel relief. You see, now they know what's causing their issues. However, this sets in motion a whole new set of emotions for both the person with dementia and their families. They are now on an emotional roller coaster with its ups and downs. The key is minimizing these peaks and valleys. These emotions will last throughout the disease and for family and friends beyond. For the person diagnosed with Alzheimer's, they may feel fear of what it will do to their family. They may become angry they have a debilitating disease. They may feel embarrassed about what others think when they make a mistake, or they may have frustration as they struggle to successfully complete tasks as their abilities diminish. Of course, this is not a complete list of the emotions a person may feel. As the disease progresses, the emotional ride for the person with Alzheimer's may actually slow, but the caregiver's emotional ride intensifies with higher peaks and deeper valleys. As my friend Rena McDaniel of the Diary of an Alzheimer's Caregiver says, on any given day, caregivers may experience several emotions. As she writes, the caregiver wakes up with trepidation, but remembers to remain optimistic. When they see their loved one and/or family, they become happy. However, they may become saddened when they see their loved one struggle. Anxiety, anger, and guilt may follow, leading to a weary caregiver who becomes resigned with the cards that she has been dealt. As she falls asleep at night, she's hopeful of what tomorrow may bring. Grief is another powerful emotion that caregivers feel on a regular basis. Among other things, they grieve about what used to be, and they grieve about what might be. Grief, as well as these other emotions, are completely natural and will vary from person to person. They may or may not experience them daily, but at some point it's likely they will experience them all. As you have likely experienced, emotions, especially the negative ones, can be very draining. Left unchecked, it's a slippery slope towards depression. The statistics on the number of dementia caregivers who are on antidepressants is staggering. Depression is a really bad thing, and it can happen to anyone, and it will hasten the progression of the disease. Denial and self-pity prevents action. In order to live well with the disease, the care partners must reach a point of acceptance. It's at this point that they can start fighting back to live well by learning ways to cope with their situation. An online friend of mine, Harry Urban, who's been living with dementia for more than a decade, said, "To live a happy life, you need to accept your disease and convince yourself that there is life beyond your diagnosis." Something else I found profound that Harry often says is, "I wonder if my life would have been as complete as it is today if I had never been diagnosed with Alzheimer's." And the answer is no, because I have found my purpose and the true meaning of life. That's just so profound. Well, that concludes my look at the emotional aspects. Now I'll talk about testing and diagnosing dementia. As of 2016, there's no definitive way to diagnose Alzheimer's disease on a living person. We can only be sure post-mortem. Diagnosing starts as a process of eliminating other possible causes. Sometimes when memory impairment is more advanced, doctors are able to confidently make a diagnosis without much testing. However, when a person is in the earlier stages of dementia, an accurate diagnosis typically involves a battery of tests. The primary doctor must first check the overall health of the patient. They will check reflexes, balance, blood pressure, sense of sight, and hearing, among other things. Lab tests will be run to exclude vitamin deficiencies and thyroid disorders that may cause memory problems. A thorough review of all medications being taken by the patient, along with an evaluation of family history, will help the doctor in a diagnosis. If you want to learn more about some of the forms that can help you be prepared for this, be sure to listen to episode 6 on creating a care plan. The doctor should ask the caregiver about the symptoms and their frequency. There are also different variations of questionnaires used for this assessment. Let's talk about a couple. The Functional Activities Assessment tool asks the caregiver to rate their loved one's ability to complete common tasks. This includes things such as balancing the checkbook, cooking meals, traveling, several other things. The Informant Questionnaire on Cognitive Decline in the Elderly. By the way, we know this is an inappropriate term since millions of people with dementia are not elderly. Anyway, this questionnaire asks the caregiver to compare their loved one's abilities to how they were 10 years ago. For the individual, the doctor will likely perform what is referred to as the mini Cog Test. This quick test involves 3 steps. First, the doctor asks the patient to repeat 3 words such as car, apple, and pencil. The doctor then asks the patient to draw a clock. That's right, a clock. Amazingly, people with Alzheimer's often have a hard time placing the numbers and hands in the correct location. I'll provide a link in the show notes where you can see examples of clocks incorrectly drawn by individuals who have dementia. Finally, the doctor will ask the patient to repeat the 3 words. While this test is not 100% accurate, apparently it's a good indicator. It seems obvious to me that if a person can't draw a clock accurately, something has to be amiss. On the other hand, I've heard of people with severe dementia that can still draw a clock accurately. And I even put those small and large hands backwards when I gave it a shot. Another common test is the mini mental state test. It's not state as in where you live, but the state of your mind. This 30-point test takes less than 10 minutes. It asks questions such as, what month is it, or what city are you in? The patient will also be asked to identify common objects and follow basic commands. The test may be administered multiple times over the course of the disease to allow the doctor to assess the individual's current condition. Taking tests such as this repeatedly can be stressful for the person who is seeing constant decline. Care partners must ask themselves if it's worth it. If the cause of the dementia is still not identified, the individual should be referred to a specialist to perform more in-depth testing. This typically involves brain imaging, of which there are 3 common types: computed tomography or CT, magnetic resonance imaging or MRI, and positron emission tomography or PET. CT and MRI scans help specialists rule out causes other than Alzheimer's disease. Problems such as stroke, tumor, or hemorrhage may provide the same symptoms. These scans can also help identify the loss of brain mass, specifically in the hippocampus. A CT scan uses a combination of X-rays, which is radiation, and computer processing to generate images. CT scans, which are painless, provide more detail than X-rays and can generate images of organs, muscles, fat, and even bone. The patient is slid into a cylinder tube while lying on their back. Sometimes a dye is injected, which helps the specialist see certain areas more clearly. The most common type of dye used is gadolinium. An MRI does not use radiation. Instead, it uses radio waves and large magnets to create images. Like a CT scan, it's painless and the patient is slid into a cylinder tube while lying on their back. A dye may also be used. Testing generally lasts between 30 and 60 minutes. If the patient is unable to lie still, medicine may be given to help with relaxation. If a diagnosis of Alzheimer's is still not obvious, the doctor may order a PET scan. While CT and MRI scans show the structure of the brain, this test uses a radioactive substance to generate images based on blood flow, oxygen consumption, and glucose use. For imaging purposes, there are currently 2 drugs approved by the FDA, Amyvid and Vizamyl. Both have different benefits and side effects. Vizamyl was more recently approved in 2013. The drugs are administered either through an injection or as a gas. It takes about 1 hour for the drug to be absorbed in the body. Again, the patient lies on a narrow table which slides into a scanner, very similar to the other imaging methods. And generally this test also lasts about 30 to 60 minutes. At this point, the specialist should be able to accurately eliminate potential causes and identify the true cause with a fair degree of accuracy. There is still a lot to be understood, and each case of Alzheimer's is different, but at least we're getting closer to an accurate diagnosis. In the show notes at togetherinthis.com/episode 10, you will find a link to 2 articles where you can read more about this process of diagnosing dementia. Now that concludes our look at testing. Now let's talk about the dementia healthcare team. As you see, just getting a proper diagnosis involves interacting with a lot of medical professionals, each of who has their own set of skills and understanding of dementia. Although we've been taught to put our full trust in our doctors, it's very important to understand what each of their roles is in dementia care. This will help you understand and make better choices based on their input. So I'm going to talk about the most typical dementia healthcare team you will encounter in the United States as it relates to dementia care. The most common medical doctor we are familiar with is the primary care physician. These doctors provide preventative care and treat common illnesses, but aren't necessarily trained about dementia or care specific to older adults. So we have geriatricians who are primary care physicians and have additional training in geriatric medicine, which gives them a better understanding of the unique needs of older adults. As a result, they should have a good understanding of Alzheimer's and dementia. In either case, these medical professionals might administer any of the questionnaires I discussed earlier. As we continue to take a look at specialized professions, we have the neurologist, who is trained in the diagnosis and treatment of nervous system disorders, which includes neurological disorders such as Alzheimer's, Parkinson's, stroke, and other types of dementia. They perform neurological exams of memory, speech, language, and other cognitive abilities, which will include necessary brain scans. The role of the next medical professional is often a surprise to people, but let me tell you, their role should not be underestimated. The geriatric psychiatrist is a physician who is trained in psychiatry, which is a branch of medicine focused on the diagnosis, treatment, and prevention of mental, emotional, and behavioral disorders. They prescribe and help manage medications. And here's why I say don't underestimate their role. I believe I told this story in episode 3 on medications, but I'm going to repeat it here. I have a friend whose wife with Alzheimer's had become withdrawn and wasn't doing many of the things that she always enjoyed. As would be suspected, he assumed it was the disease. Because of issues with their health insurance, they did not visit their geriatric psychiatrist for several months. Once their insurance issues were resolved, they were able to visit the psychiatrist, who immediately changed the pain medication his wife was taking. Almost instantly, she was back. She was cooking again, and they were even able to attend local soccer games for one of their family members. Wow! Managing medications is complex. And unfortunately, we have to accept that many doctors don't have the time and aren't necessarily trained to understand and identify bad medication combinations. So we have to turn to those who are, and that includes the geriatric psychiatrist and our pharmacist. The pharmacist is the medication expert. They advise other medical professionals, patients, and caregivers on the selection, dosage, usage, and side effects of medications. In my ignorance, I didn't realize that until I did my research. Often you can even make an appointment with them and ask them to review a list of medications your loved one is taking. What an invaluable resource. Next, we have a clinical psychologist. This is the shrink we typically think of and is often and incorrectly confused with the psychiatrist that I previously discussed. However, they are not a physician and they cannot prescribe medications in most states. They focus on the assessment, diagnosis, and treatment of individuals, couples, and families who are suffering psychological issues. As I previously discussed, the emotional roller coaster can be intense, and this professional can be a huge asset. The last member of our dementia healthcare team is the occupational therapist. In my opinion, this is one of the most underutilized professions for any family caring for a loved one at home. The occupational therapist helps people perform at their highest ability, whereas a physical therapist helps people recover from something. The OT helps people successfully accomplish everyday activities. As you know, things such as bathing, dressing, eating, and toileting can become more challenging for the care partners. The OT will help implement techniques to make these activities easier and should definitely be consulted when caring for a loved one at home. Please understand this list is not inclusive and it focuses on what we have here in the United States, but professionals in other countries have very similar roles, just maybe different titles. That concludes our discussion for this episode. In this episode, I discussed the emotional roller coaster and how it's important to minimize the highs and lows. We also talked about how it's important to get through the denial and accept the disease. Next, we discussed how there's no definitive way to diagnose Alzheimer's in a living person, and you learned about the extensive testing involved to get a proper diagnosis. This includes, among other things, questionnaires and brain imaging to eliminate potential causes of dementia. I then covered the dementia healthcare team, and you became aware of the various roles and skills each professional has, and you're now able to utilize them to best serve your needs. As I mentioned in the beginning, this discussion is derived from a very popular and free Introduction to Alzheimer's Disease course. This course includes additional resources and tools you can use to improve your knowledge. If you're looking to really build a solid foundation of knowledge, then be sure to check out the show notes for a link to this course, as well as all the other resources I may have mentioned. Again, thank you for joining me today, and I look forward to talking with you in episode 11, where I'll discuss treatments for dementia, person-centered care, types of support needed, and the legal and financial aspects. Bye-bye. You've been listening to the Alzheimer's Podcast with Mike Good of Togetherness. For more information and to get the resources mentioned in this episode, visit togetherness.com/podcast.